welcome everyone. I hope everyone had an easy way of getting in today and no struggles. My name is Jamie Peters. I'm a registered nurse and certified respiratory educator. I've been a nurse here at LungSask for almost 18 years and have spent the last 5 or so helping manage this support group in partnership with the interstitial lung disease nurses from Saskatchewan Health Authority. So just a little background information for the last 110 plus years, Lung Saskatchewan's been at the forefront of improving lung health in Saskatchewan. Our mission statement is to improve lung health one breath at a time. We've been a trusted partner in lung health for educating on lung disease and threats to lung health, advocating for policies that protect lung health, and investing and participating in lung health research and care. We are a source of information and support on your lung health journey. Before we get going in introducing Dr. Marcoux, we need to acknowledge the land we are on. We are hosting this webinar today on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, and as well as the homeland of the Métis. Our presenter today is Dr. Marcoux, Dr. Veronica Marcoux. She's Saskatchewan's very first respirologist who is specialized in the management of interstitial lung disease and pulmonary fibrosis. Dr. Marcoux completed her medical degree and respirology fellowship here at the University of Saskatchewan, and this is followed by a 1-year fellowship at the University of Saskatchewan in the sub-specialization of interstitial lung disease or pulmonary fibrosis. She's been back in Saskatoon, which we're happy about, since 2019, and currently co-leads the Interstitial Lung Disease Clinic with Dr. Stacey Locke here in Saskatoon, which is a participating site for the Canadian Registry for Pulmonary Fibrosis. This is a database that we actually talked about in September in our support meeting that's used to further research and help gain a better understanding of these lung diseases. She also has 2 interstitial lung disease nurses who work closely in the program as well. And of course, Nurse Shane is here with us today. Before I pass this to Dr. Marcoux, I want to remind you that we are recording the session for today for those who can't attend. But all attendees' questions and comments will be removed before it is posted online. And just a reminder that this is a confidential space and personal stories are not to be shared outside our group. We will have time at the end of the presentation for questions for Dr. Marcoux. So I am going to pass it over to you now and let you start your presentation, Dr. Marcoux.
Okay, thanks. Thanks for the introduction. I didn't know, Shane, if you wanted to say anything first, but also like if people type any questions into the chat and if you think that there are something you want to address as we go, I'm happy to do that as well. I'm hoping that there'll be lots of time at the end for questions. So like I was going to talk about cough because I suspect that this is a highly relevant topic for most people. So in order to just gain some understanding about where we're coming from and then gain a bit of understanding about where patients are coming from, I was going to review really basically lung anatomy and then kind of what is interstitial lung disease or pulmonary fibrosis in very broad terms, some of the symptoms, what cough is, and then maybe just so that you can get a bit of insight into how your doctor is actually approaching cough and the way that we try to work through it, because sometimes there's not just one cause. And then how cough is known to affect daily life, what things we can do to treat, and then what maybe is coming in the future for treatments of chronic cough. So just really quick, basic, I don't want to overwhelm anybody with information, but just so we're all aware of what we're talking about and then where some of these terminologies come from later on. So when we talk about the respiratory tract, we see over here on the side of the screen, there's the upper respiratory tract and then there's the lower. So the upper, we have to remember, like everything that can contribute to cough lies all the way along here. And so the upper airway includes like the mouth, the back of the throat, the sinuses, the nose, basically anything above where your voice box is. Which is this little cartilage structure right here called the trachea, which extends downwards. And that's just that large tube that leads down into the airways and then splits to the 2 sides where you've got your lungs. So cough can essentially originate from irritation or something that affects these regions all along there. And then if we kind of expand or focus in a little bit more on the lower respiratory tract, this again here in the middle is the trachea, which branches to the two sides, the right and the left lung. And then you have to remember, like, these structures branch extensively. So they'll divide over and over and over. And the whole point of them dividing is every time they divide, those airways and the blood vessels that run with them get smaller and smaller and smaller. And then eventually they divide so many times that the tissue becomes essentially microscopic. And what it's trying to get to the very end to in your lung are these little units called the alveoli, which is where gas exchange happens. And so that is kind of the end point of that division. And so as you can imagine, if cough can arise from anywhere along here, all the way up even to your nose, sometimes there's more than one reason a person can cough. When we think about the lungs and kind of how they're affected in interstitial lung disease, if we really zoom in on these little air sacs here called the alveoli, you see that there's this tiny little airway that comes in and then branches into the alveoli here. And this is where your gas exchange actually happens, how you get oxygen into your blood, and then that carbon dioxide gets blown out, and then you exhale that bad gas out. And then I don't expect anyone to know this. There's not going to be a test or anything, but just in case anyone wants to really see what this stuff looks like under the microscope, if you were to have a lung biopsy or a piece of your lung cut out, what we actually see here is these units of alveoli are like microscopically thin, like you would not be able to see them with your blind eye. So this is under a microscope, like multiple different levels of power that we can see. And as you can tell, it's a lot of difficult things to interpret, but these are like the tubes, the airways here, and all these little fine structures here that are basically just a cell or two thick. That is where all of our gas exchange happens. And so they're extremely delicate and need to be extremely thin. And so when people develop any fibrosis or thickening of this, as you can imagine, that is what can lead to impaired gas exchange. And then we'll talk a little bit about some of the reflexes that can happen that cause cough. So just to impress upon you, like how microscopically thin the lungs eventually become because of all those multiple divisions. And then interstitial lung disease, unfortunately, is not like a easy concept to understand either. It's not a diagnosis. It is a category of disease. And the other term you'll hear us use sometimes is pulmonary fibrosis. So these are two interchangeable terms, which can be confusing. And they're the umbrella terms for over 200 specific diseases. And so sometimes the term pulmonary fibrosis can be a little misleading because it implies that there is fibrosis or scar tissue. But in some interstitial lung diseases, that's not always the case, and it can be solely inflammatory as well. So that's what you'll hear us kind of flip sometimes between those two terms as interstitial lung disease or pulmonary fibrosis. The interstitium itself, which is that word in interstitial lung disease, it is our scientific fancy word that we use to describe the support tissue that actually makes up your lungs. So if you think back to that lung biopsy picture I showed you, that is almost like a scaffold, right? Something has to hold all of that stuff up. And what you want it to be is a nice, well-organized structure so that one, it's good for gas exchange. Two, it's strong enough to hold everything up. And three, you want it to be functioning properly so that if there is a minor injury, it can repair and remodel itself. But if you start to get fibrosis, that can lead to disorder of that nice fine web or structure, if you will, and you can start to get thickening of that support tissue and even destruction. And so these are conditions that can affect that and cause essentially shortness of breath, cough, and reduced exercise levels. And then just one more super basic picture, just to imagine this alveoli, if you just want to picture it as one big circle. When the blood vessel goes by, you breathe your bad gas out, and then you get your oxygen back into that blood, and then that's how you basically get blood flow through the lungs. And then to add it even more complexity into it all, because I said there's over 200 specific diseases that fall into this category of ILD, there are many. And so in order to also be able to appropriately treat someone's cough or symptoms, it's important to know what the actual diagnosis is, because sometimes the approach to different diagnoses will mean different approaches to treatment of symptoms. And so the way that we try to break that down is by known causes. So we know certain autoimmune conditions can cause fibrosis or ILD, definitely exposures, whether they be organic, such as bird feathers, inorganic, like asbestos, medications, even radiation, post-infection, or inhaled injury from cigarette smoking or vaping. Then there's a whole other category of cystic lung diseases, sarcoid. And if we can't find a cause, then sometimes we get left with that idiopathic category. But I don't intend anyone to remember this stuff. I just want to hopefully impress upon you that there's a lot of thought that has to go into figuring out the diagnosis, because we will treat symptoms differently depending sometimes on what the diagnosis is. But the big common theme is that all of these conditions, if they can affect your lung, do cause symptoms. And if it becomes obvious enough, then people can start to develop shortness of breath, which they may first notice when they're walking, may eventually worsen to the point of being short of breath at rest, chest tightness, wheezing, reduced exercise tolerance, fatigue levels, and then of course cough, which is what we're going to focus on today. So what is the thing that actually causes cough? Well, you have to think about this as a reflex. So cough is just your body's reflex reaction to some kind of stimulus. And so every single time you cough, that's actually a pretty complex nerve reflex arc. Kind of like if you think of when the doctor tests your reflexes in your knee, where they tap the knee, what happens is a nerve carries that stimulation back to the spinal cord, and then it automatically shoots out a movement. And that's kind of what happens with cough. So there's lots of little receptors and nerve fibers that can lie in your lungs, the upper and the lower part of the airways, even in the lining of the heart, lining in the stomach and the esophagus. So if anything is irritating to those cough receptors enough, it will trigger that cough reflex. And cough receptors can be triggered by a variety of things. So things like mechanical irritation, which can even include like if there's chemical irritants such as refluxing of acid, inhaled perfumes, fumes can induce cough, cold temperatures, heat may exacerbate for some people. And so it very much depends on the person. And then what happens is if you imagine you've got this little nerve, this is a nerve right here, it detects an irritation, carries it back into the brainstem, and then automatically fires out to another nerve to do the cough, right? And so it's a reflex, and that's why it's really hard to control, and also unfortunately why it's really hard to treat, because there can be multiple different reasons for cough. So when we talk about cough in the medicine world, the way that we're taught to think of it and then therefore treat it properly and examine properly is based on how long has the cough been going on. So it's basically broken down into acute, which means 0 to 3 weeks is kind of the timeline of when someone has started to cough. Subacute, which means it's lasted longer than 3 weeks, but not quite out to that 2 week or 8 week, which is 2-month period. And then once it starts to last longer than 8 weeks, that's when we define it to be chronic, meaning that it hasn't gone away. And that's essentially what we're all going to be dealing with. But you have to remember that, sometimes a person with interstitial lung disease can also have an acute reason to cough, right? So such as an infection, which will resolve. And so there may be those little blips along the way as well. And so for each of these, there's definitely have to do a detailed history, figure out what's going on, what comes up, as far as medical histories, exposures recently, and then also the examination to listen to the lungs. Maybe there's some new crackles, or maybe there's something to point towards an infection. And then of course a chest x-ray. And the reason that that's important is we have to kind of approach it with fresh eyes every time something changes, is because there are lots of reasons for people to have a chronic cough, even people with pre-existing lung conditions. And so cigarette smoking, even secondhand cigarette smoke exposure, active vaping, inhaled marijuana use, those can cause cough. And then the 4 most common things that cause chronic cough are asthma, something called non-asthmatic eosinophilic bronchitis, which is type of inflammation of the large airways that can cause irritation and cough, acid reflux, and an upper airway cough syndrome, which is the fancy term that we've given to the cough that happens when you have sinus congestion and postnasal drip. Postnasal drip is a tricky one because sometimes only about 40% of people will actually feel that dripping at the back of their throat. And so sometimes what we will do is just empirically trial a treatment for it to see if that makes it better. There's also medications that can make people cough. The biggest ones being a class of medications called ACE inhibitors, which are blood pressure pills. And those always end with a pril at the end. So, ramipril, lisinopril. So if somebody's on that and they still having quite a bit of bothersome cough, sometimes we'll suggest changing that to a different type of blood pressure medication to see if it helps. And then also the latanoprost or timolol eye drops have been implicated to actually cause some issues with cough because you put them in your eyes and then it can go down through the eye ducts into your sinuses, and in some people cause irritation and coughing. There was another potential concern around a diabetic medication called Januvia, but that one didn't really bear out to actually cause significant cough. So ACE inhibitors, and less likely these eye drops. So the doctors will be on keeping an eye out for that in people who have chronic cough. Of course, interstitial lung disease all on its own can cause coughing. If somebody has untreated sleep apnea, where you're basically having apnea events all night long, that actually induces a bit of acid to come up every time people try to breathe when they can't because of their apnea events, and then that leads to refluxing up onto the vocal cords and coughing. Any recent infection, unfortunately, we know that post-COVID can induce a lot of issues with cough. People who have COPD or chronic bronchitis or emphysema, if there's a chronic infection, accidentally always choking on foods or sputtering or things going down the wrong way. So as you can imagine, this is a pretty long list of causes of chronic cough. And somebody can have 3 different things off this list that's causing them to cough. And so you kind of have to manage each one individually. And then there's even more reasons that people can cough. So even having, say, a chronic buildup of pretty bad enough earwax can actually induce people to have issues with coughing. And so making sure that if that's building up, seeing the doctor to make sure that that's cleaned out. So there, obviously, I don't need to tell you guys what the impacts of cough are, but I just hope that you guys realize that we do recognize it's a significant problem and it can definitely impact daily life. There was a study done in Australia where they did an interview with 16 patients with all different types of fibrotic lung disease. And they asked them and tried to just get a better sense of like, how do they describe their cough characteristics, what kinds of things they felt were triggers and how it impacts their life. And I'm sure that you can probably recognize some things here, right? Everyone will experience their cough in their own individual different way. People will describe the frequency, how long it's been going on. Does the stuff come out when you cough, like lots of sputum? Sometimes it can predate your diagnosis, right? And just slowly get worse over time. And I'm sure that you can maybe see some reflections of someone or yourself here where people say, well, it's continuous. It's spasms of coughing and you can barely get a break from it. It can be debilitating and it can be very difficult to bring that sputum up when it's really sticky. What are some of the most commonly identified triggers from a patient perspective? Well, definitely aerosols, so even perfumes or irritating smells, fragrances, infection. Some people find that the humidity closer to sea level actually helps. Cold air sounds like it's a pretty bad trigger for lots of people. And we know that poor air quality can also be a huge trigger. So avoiding air pollution, especially during forest fire season, which I think is going to only get worse over time, is important because that can make your cough worse. Even certain foods, definitely like milk products, some people find really makes them even more phlegmy and can make your cough worse. Talking and laughing, well, that's pretty interfering with your life on a daily basis. So that's why we try our best to treat it. And it can make you feel short of breath. We know that there's physical symptoms associated with it too, like coughing so hard that you throw up or having dry retching and disruption to sleep. And then, of course, the whole social and emotional impact and toll that it has, where people feel self-conscious, and especially during COVID, going out and coughing was almost like something that you would just do anything to avoid. And so, this is why it's important to treat cough, not so much that sometimes it's harmful, but it's an extremely bothersome symptom that is very impactful on quality of life. So when it comes to the treatment, this is one thing I always emphasize, especially if people smoke, is that no matter what I do, no matter what treatments we do, if someone continues to smoke, it's going to be pretty difficult sometimes to control the coughing. And especially if there's even secondhand smoke exposure, vaping, e-cigarettes, marijuana that's inhaled. So that is a key overlying component to treatment of cough, is if that's something that someone's doing until they're able to quit, that may continue to drive the cough. And then if you think back to that huge list that I just showed about all the different causes, I hope that this is just one example to just show you how we approach this. So if you had a 68-year-old with a diagnosis of idiopathic pulmonary fibrosis, which is a specific disease, and they also used to smoke, and it also has significant sinus congestion with postnasal drip, every day getting uncontrolled heartburn symptoms, also has a diagnosis of COPD from prior smoking, and they're on a high blood pressure pill called Ramipril, which is that ACE inhibitor. So the way that we would approach this is we have to treat every single thing that we know could be causing the cough, in addition to then also talking about what we do in that specific condition. So, we would want to try to get better control of their nasal symptoms. That can sometimes just be using like a neti pot to keep better sinus hygiene, plus minus sometimes those intranasal steroid sprays that we use, like say Nasonex or Flonase. Things like Dristan or the decongestants can actually make those symptoms worse. And so that's why we try to avoid those, because if you use them for longer than 3 days in a row or so, it'll actually make the opposite effect that you want. And antihistamines are also sometimes helpful. And then if there's ongoing reflux, and that just means acid is coming up into the upper airway, and then causing a lot of secondary irritation of the larynx, that can cause voice changes and issues with coughing as well. So we would want to try to target that and reduce reflux symptoms with medication, target the COPD potentially, which is usually treated with inhaler therapy, and then see if we can get this medication changed if, despite all that and our best efforts, people are still having symptoms. So as you can see, unfortunately, it's not like a straightforward answer, and unfortunately, there's no straightforward treatments. When we talk about chronic cough in general, some of the just overarching principles to treatment: one, non-pharmacologic treatment, which is a trial of essentially like speech language pathology management, or SLP. These are professionals trained in not only speech, but also swallowing reflexes, and they can also assist with training people to try to get better control of the urge of their cough, and to therefore also reduce their cough sensitivity. So that's always a potential option as well when we cannot get people's cough under control. The pharmacologic, which means medications, include the antitussives, which are all just your anti-cough medications, such as Benylin, what's the other one? Buckley's, right? Mucinex, which is one to try to reduce the sputum production itself. Sometimes if there's a lot of sputum production, especially in people who have underlying airways disease, there's a medication called N-acetylcysteine, which has been trialed to reduce sputum volume. And then even in chronic cough patients that there's no identifiable cause, there is some minimal, if not great, evidence to show that certain drugs that can affect that nerve reflex that causes the coughing, such as gabapentin, pregabalin, which is known as Lyrica, or amitriptyline, can be trialed to see if it reduces the cough. And usually you'd want to give it at least 6 months. We know that opioids, so those are pain medications or narcotics, as the other terminology. Those drugs, such as morphine, Dilaudid, methadone, those are all medications that ideally we think of like, oh, those are pain drugs. But we do use them in more advanced symptoms, such as shortness of breath or cough, because they also act on receptors in that reflex that I showed you that induces cough to basically reduce that reflex and suppress cough. And we do have some evidence for these medications even in ILD, so idiopathic pulmonary fibrosis, or IPF. There was a very good recent trial that gave people 5 milligrams of morphine to take by mouth twice a day. And then they compared it to a placebo pill. So that means there's nothing in the pill. And they did find that there was a 39% reduction in cough, which is pretty good, all things considered. But usually when we start taking medications like that, that's usually more in a really bothersome phase of somebody's life. And so it's not to be taken lightly, but certainly something that can be considered if we've exhausted all of our other options and it's bad enough. If people are having recurrent drops in their oxygen levels, including at night when they're sleeping, that can also actually induce people's cough. And so if someone needs oxygen and they're not wearing it every time they exert themselves, wearing supplemental oxygen and avoiding getting those really low oxygen levels will actually help alleviate cough as well. You may have ever sometimes come across, or if you do a lot of reading online, there's this talk about actually just doing a nerve block where you just block that nerve itself so that they can't get the reflex that is the cough, but that has not been studied in ILD, so it's not something that we routinely do. So those are just general principles. And then I'll go over two very specific examples. So I just picked out two diseases. Of course, as you saw, there's over 200. Idiopathic pulmonary fibrosis is one of the more common diagnoses. And then there's another condition called fibrotic hypersensitivity pneumonitis. So I'll just give some examples of how or what else has been shown to be helpful in those two diseases. So in IPF, up to 80% of people with IPF will have cough, and that's probably just through like one snapshot survey of people. What happens is people with IPF can also develop this increased cough stimulating response. So meaning that there's an increased sensitivity and an increased urge to cough. Also probably because of destruction of the normal healthy lung tissue. And you imagine all those little tiny nerve fibers coming down into that fibrotic lung. It's really irritating for those fibers, and any kind of movement when you're breathing can induce irritation and cough. And so trying to treat those mechanisms can be quite difficult. So obviously the biggest thing is we want to prevent progression of people's disease, because as the conditions get worse, so can the symptoms, including cough. And so that's why we talk about these antifibrotic therapies, even right up front, even if you have no symptoms at the beginning, because we're trying to preserve that lung function for as long as possible and hopefully delay these symptoms. So the two antifibrotic drugs are both Ofev and pirfenidone. Pirfenidone also has some evidence to show that in patients taking it, that it has reduced their cough after the 52-week period. Ofev didn't have as much strong data to support that yet, but pirfenidone does have some evidence to reduce cough. Of course, sometimes if we're really struggling and in more an acute reason for an increased cough, such as infection, anecdotally, meaning that this isn't supported by evidence, there can be some success with short-term low-dose courses of prednisone in acute events for coughing. In case anyone ever goes online and is trying to read around some of these things, things that we don't use, and there's reasons that we don't, thalidomide. If anyone remembers back, this drug was initially used to prevent nausea in pregnancy and resulted in a lot of defects at birth. But it was actually trialed to see if it could reduce cough, and it did in an IPF trial, but it had so many side effects that it is absolutely not worth using. So we just do not use this drug for that. There was also an inhaled medication called cromolyn sodium. It unfortunately didn't work. There was this molecule called gefapixant that everyone was quite hopeful for to reduce cough, but unfortunately, when they ran their trial, it was not helpful. Sometimes in COPD or airways disease, we will use chronic azithromycin, which is an antibiotic. In those other conditions like COPD, it can have an anti-inflammatory effect. But when it was tested to see if it would help reduce cough in IPF, again, unfortunately, it wasn't helpful. And another unhelpful trial was this interferon alpha, which was an actual lozenge that people could suck on. And again, unfortunately, even though it's really small studies, only 12 people, there was a bit of a positive signal, but no further study was done. And so sometimes we're also limited by actual studies and investigations. So as you can imagine, obviously our biggest goal is to prevent progression in IPF. And then some of those other overarching principles that I mentioned here about the non-pharmacologic and pharmacologic things we can trial. And then, hopefully some things coming on in the future. So let's talk a little bit about therapies that can be targeted to the specific diagnosis, such as fibrotic hypersensitivity pneumonitis, which is a condition that involves inflammation of the small airways as well as the lung tissue itself due to something that people are inhaling in their environment, either continuously or recurrent low-level exposures over time, and then that injury leads to scar tissue. So the biggest thing that we need to do to identify is what is the thing that the person is inhaling, which unfortunately in half of people that's not possible. But if you can identify it, then that is key to remove from the environment because it will continue to induce symptoms, including cough. And then the other thing is having good, clean air quality. So air purifiers with HEPA filters in rooms that you spend a lot of room in, making sure that your ducts of your furnace are cleaned, and then certainly having HEPA filters on your furnace itself, because air quality is really important in these diseases. There was actually a recent study that was just published not that long ago where they looked at the antifibrotic called OFEV in non-idiopathic pulmonary fibrosis patients who were getting worse. And they did show with that drug that it reduced the cough after 52 weeks versus placebo. So again, that's a positive signal that I think could probably be extrapolated. So the two antifibrotics have some evidence, right, to reduce cough. And then, of course, the medications specifically targeted to treat the fibrotic hypersensitivity pneumonitis, such as short courses of prednisone at the beginning, or the other two immune suppressing medications called mycophenolate or azathioprine. Presumably, if we can sometimes gain control of the inflammation or airways disease, might reduce symptoms. So then what's coming in the future? I'm hopeful that there's a few things that we might have available. There's this medication that's being run in a really large trial right now that had a really positive signal. It's called nalbuphine. It is a mixed synthetic opioid, meaning it has both, it acts on the receptor and also blocks the receptor. And it's felt to maybe be more beneficial over, say, morphine or Dilaudid because it's supposed to have less systemic side effects. And it can also just be discontinued rapidly. So they ran a really small trial in people who had IPF. And they did find that when the people were taking this pill twice a day, after 3 weeks, they did have a pretty big reduction in their cough. And the way that they actually measured the cough was they had people wear these monitors that would count every time they coughed. So it was actually an accurate measurement of frequency of cough as opposed to relying on people's memory. And it reduced their cough by 77%, which is pretty amazing. In the placebo group, there was a 33% reduction. So who knows what that's about, but that's still a pretty big difference, right? Of course, all of our drugs that we use in the ILD seem to cause some kind of GI side effect. So nausea was one of them and constipation was another. But all the people who got through the initial dose titration phase, once they got through that phase, everyone was able to stay on it for the 3-week study period. And so now they're running a much larger multi-country, multi-center trial. And hopefully that will be planned to complete by April 2025. So perhaps this medication will be in the future something that we can utilize to treat cough. There is a Canadian study running out of Hamilton right now, which is based on the SLP techniques I was talking about before of non-pharmacologic, meaning no study drug. It's patients who have ILD, so not restricted to IPF, and they're essentially running it virtually. So you don't have to actually physically be there. And what they're doing is doing a few different educational and self-management techniques to try to suppress cough. And then they're measuring all sorts of different measures of self-reported cough and quality of life. I tried to reach out to the person who is the contact for this study. I didn't hear back yet, but the one thing that stuck out to me is that they are still recruiting, and it's virtual. And they did not have a restriction to being only in Hamilton and Ontario. So if I find out more about that, definitely we can spread the news, because perhaps this is something people would be interested in being participants in. And then there's lots of like other things on the horizon, right? Like I'm really hoping that someday we're going to start getting some better medications, not only to treat the fibrosis, but that will also start focusing on quality of life, because we know that patients find that to be the most important thing. Because right now, all of our trials, we focus on endpoints like what's the decline in lung function over time. But we know that these other things, such as cough and shortness of breath, are obviously just as important. There's two small studies looking at these two drugs called duloxetine and amitriptyline to see if those reduce people's cough with ILD. There's still lots of ongoing trials with the medication called Ofev or nintedanib, looking to see if it reduces cough. And then I came across, there's another study that's running looking at something called Suplitast, which is actually an immune medication that they use to treat asthma in Japan. They're doing a trial to see if that reduces cough, which should be done by March of 2025. And there's this brand new molecule that BI has not given a name to yet. That's Boehringer Ingelheim. They're the company that makes nintedanib. It's a molecule that they're looking to see if it reduces cough in people who have progressive phoretic lung disease. And their anticipated end date is July 2025. So here's hoping that that's going to be a positive trial, because they don't describe it as a treatment for fibrosis, but actually something to help with cough. I came across this one other thing in case anyone's ever Googling randomly online, is something called sodium pyruvate nasal spray. And I actually polled my colleagues across Canada, and so far nobody has said that they've heard of this. But this was based out of a very small trial in the US where it's a no spray that was shown to reduce cough. But the one thing I thought was a little funny about their trial was it was self-reported cough. And so that's a little bit more unreliable. But they did find that everyone's cough reduced. So I'm going to keep trying to dig into this and see if there's anyone out there who knows much about this nasal spray. And then the last thing I just want to make sure is that like where everyone needs, just be aware of what you read online. When I was prepping for this talk, I Googled Ofev and cough, and this is what came up, which is completely wrong. It says that a dry cough is a side effect of Ofev, and all of this is wrong. Don't read it. Just be aware what you read, because this came up from an AI generated summary on my desktop. Didn't show up on my phone when I did it, but it does come up on the desktop when you Google things. So just be aware, AI is still experimental. So trust your care providers. And then, yeah, I just wanted to put a nice plug again out for Care PF, because Dr. Locke and I are both the local investigators here in Saskatoon. We're a site across Canada. It's the largest registry in the world and has like 40 plus very influential publications so far, and continues to be very productive. So if it's something you're interested in, if you see us in clinic, bring it up. I hope that wasn't too bad. I'm sorry I don't have more positive medications I can add now, but I do hope that in the next year or two, we're going to start getting better options as well.